Hello class. In this recording we're going to be talking about chronic renal failure. Chronic renal failure is a progressive condition that occurs over months to years, and it's not reversible, and it's secondary to other chronic conditions. In chronic renal failure, 90 to 95% of the nephrons are involved. Chronic renal failure is fatal without renal replacement therapy or a transplant. Some key terms I want you to be familiar with relative to chronic renal failure. The first one is azotemia. Azotemia is a term we use to describe buildup of nitrogen-based waste in the blood. Another term is uremia. Uremia is a term that is used when the condition advances to the point that the kidneys are unable to maintain fluid and electrolyte or acid-base balance. It's also referred to as end-stage renal disease. Key features of clients that are in uremia, so the key signs and symptoms are the patients will complain of having a metallic taste in their mouth. They may experience GI symptoms such as anorexia, nausea, and vomiting. Muscle cramps are also common. Another condition is uremic frost on the skin, and I've got a picture of that later on we're going to look at, and itching. They may complain of fatigue and lethargy. They may also have hiccups and swelling, dyspnea, and some will complain of paresthesis. Another term I've got listed here is creatinine clearance. You'll recall that creatinine is the end product of metabolism. We've already talked about creatinine in another recording. Normal creatinine blood values for males are 0.6 to 1.2 milligrams per deciliter, and for females it's 0.5 to 1.1. In chronic kidney disease or chronic renal failure, we may see the creatinine increase by 0.5 to 1 milligrams per deciliter every 1 to 2 years as the condition progresses. And the creatinine can actually get as high as 15 to 30 milligrams per deciliter before symptoms of severe chronic kidney disease are present. So the creatinine clearance test is a blood test coupled with urine sample that's used to determine the rate at which the kidneys clear the creatinine from the blood. And this is reflected as the glomerular filtration rate. So as we look at how chronic kidney disease progresses, we're going to be following what happens with the glomerular filtration rate. A creatinine clearance test is obtained again with a blood sample and a 24-hour urine sample. So with progression of the chronic kidney disease, you'll note that the glomerular filtration rate declines as the disease progresses. We typically classify patients in the various stages to track, particularly used to track research and all, but also to document the patient's decline in condition. The first stage that we see with chronic kidney disease are those that are at risk for the condition. The two primary risk factors for chronic kidney disease are uncontrolled diabetes and uncontrolled hypertension. And these account for more than 2/3 of the cases of patients that have chronic kidney disease. High blood glucose levels damage the walls of the nephrons by thickening them and making them leak. This thickening causes the kidneys to have to work harder to filter the blood. And over time, the nephrons become ineffective at filtering. With the hypertension, think of the blood pressure as a force of blood against the blood vessel walls. The increased pressure makes the arteries around the kidneys narrower, weakened, and hardened. This results in decreased blood flow through the kidneys, and so then eventually the nephrons don't work as well. Some other conditions that can lead to chronic kidney disease, we've already talked about some of these in our prior recordings, but you'll remember congenital or inherited conditions, cardiovascular disease such as ischemic heart disease, heart failure, and so forth. We talked about some nephrotoxic drugs, and we're going to talk about those a little bit more in another recording. Any condition that causes the blood to be altered, such as sickle cell disease, again, diabetes. We see it also with clients that have systemic lupus erythemosis, chronic glomerular nephritis, nephrosclerosis, chronic infections such as hepatitis C and B, HIV, and polycystic diseases. So you can see that with the stages, stage 2, we have more reduction in the glomerular filtration rate, and eventually it gets to the point where with the kidneys they actually are not hardly filtering at all. I want you to take a look at how this lady changes with these different slides. So we got this lady, and she looks pretty healthy, but she's has some diminished renal reserve. And then she gets a little bit worse, and then eventually she ends up in a recliner. And I always think about these recliners with the dialysis patients, because this is where they end up, once they go on dialysis, is in a recliner. So as we're looking, as the patient declines over time, they start out with a glomerular filtration rate with a small amount of diminished reserve. They're still doing a pretty good job at filtering. They're at risk. They have uncontrolled blood pressure oftentimes, and we're going to get a 24-hour urine for a creatinine clearance to try to monitor these patients. They may begin to have increased problems with the glomerular filtration rate after this stage. But right now they're at a normal rate with the glomerular filtration rate. They may have a decreased urine concentration, and they may have nocturia. The key during this stage is to treat the comorbid conditions and get control of whatever is causing them to be at risk, such as their diabetes and hypertension or renal artery conditions. Then as they decline more, they're going to be complaining of headaches. They have a decreased ability to concentrate urine, and their polyuria will change over to oliguria possibly. Their blood levels of their BUN and creatinine are going to begin to rise. They're going to have edema, and they're going to start showing signs of decreased glomerular filtration rates. They may be mild anemic. Again, their blood pressure may still be elevated. They're just going to feel pretty bad. At the end stage, again, their glomerular filtration rate is going to be less than 15 milliliters a minute. They may suffer from neurological conditions, weakness, fatigue, and confusion. Their blood pressure may be up. They may have edema. Their central venous pressure is going to be up. They're going to possibly be short of breath. And again, they're going to have the signs and symptoms of uremia that we talked about a few minutes ago. They may also be anemic and have dry, itchy skin, and again they're going to have some muscle problems as well. At this point they're probably going to have to go on some sort of dialysis. So the key manifestations of chronic renal failure are azotemia, and this is where the body loses the ability to concentrate urine, and it results in an increase in the waste products in the blood, and the urine's real dilute. They may suffer from hyperkalemia because, remember, the kidneys are the primary source of excreting potassium. They may also have low calcium. Diseased kidneys lack the enzyme that activates vitamin D, so without vitamin D, absorption of calcium is decreased in the gut, and the body compensates by shifting calcium from the bones to the blood. Serum phosphate binds with calcium and further depletes calcium levels. The decline is also possibly going to show signs of metabolic acidosis. The renal tubules fail to excrete the acid ions, and acid waste products begin to rise in the bloodstream. Decreased bicarbonate reabsorption renders the body unable to compensate, and so the lungs attempt to compensate by eliminating more carbon dioxide through hyperventilation. So you'll remember that when our patients have metabolic acidosis, the lungs try to compensate by trying to breathe out that carbon dioxide. We have problems also with fluid balance as the patient retains sodium in water, causing hypernatremia and hypervolemia, and thus they will still have more high blood pressure and edema. They can develop heart failure as well. They also may show insulin resistance, where the cells become resistant to the action of insulin. With renal failure, blood glucose and insulin levels rise. Hyperinsulinemia stimulates the liver to produce triglycerides, which can lead to hyperlipidemia and contribute further to the atherosclerosis. Anemia is also a common manifestation. The kidneys produce less erythropoietin. The EPO is a hormone necessary to produce red blood cells. The red blood cells produced by renal failure patients have a shorter lifespan due to the uremia that's happening there in the blood. So these patients naturally become anemic. Often they also have iron deficiency. Iron is a building block of red blood cells. So as we begin to look at these patients, they have multiple system alterations. They have less resistance to infections. They have more problems with heart failure and cardiac arrhythmias because of the changes in the vascular system, because of changes in the electrolyte balance. They may also have altered mental status and depression, and so they just absolutely everything starts to fall apart for them. This just shows you a slide of some of the clinical manifestations. There are numerous manifestations with this condition. This shows you the urea crystals and the uremic frost that happens on the skin as this builds up in the tissues, because the body's not getting rid of that. So our nursing concerns, there are several nursing concerns with chronic kidney disease. As we're going back and looking at these stages, in stage 1 Your role is to screen for risk factors, to monitor for uncontrolled hypertension and diabetes, and any type of chronic kidney or urinary tract infections, screen the patients for genetic problems, and exposure to nephrotoxic substances. Now, some examples of nephrotoxic substances. We're going to talk about those in another recording, but aminoglycosides, ibuprofen, there are several. We're going to talk about those later. In stage 2, you're going to focus on risk reduction as well. And in stage 3, you're going to implement strategies to slow the progression of the disease. In stage 4, you're going to manage complications and prepare them for eventually being on dialysis of some sort. And then in stage 5, they're actually going to be put on dialysis or have to have a kidney transplant. One of the major nursing concerns and nursing strategies is managing fluid and electrolyte balance. For managing fluid balance, we're going to weigh our patients every day and obtain an intake and output. We're going to monitor for weight gain and monitor for an intake greater than an output. Remember, 1 liter of water weighs 1 kilogram. So as we start to see our patients gain weight, we'll know how much fluid they've got excess. We want to teach the patients about keeping up with their intake and output and following any restrictions. And most of these clients are on a 24-hour fluid restriction of some sort that's outlined by the physician. We want to monitor for signs and symptoms of fluid overload, such as decreased output, rapid bounding pulse, shallow rapid respirations, edema, crackles and wheezes, distended neck veins, elevated blood pressure, and so forth. As far as the electrolytes goes, hypocalcemia is treated with calcium supplements, active vitamin D, and phosphate binders. We want to give those with meals but not with other meds, and we want them to avoid magnesium and acid because magnesium will be high. As far as potassium goes, we may be administering IV glucose and insulin or bicarb to drive the potassium back into the cells and reduce the potassium levels in the serum. We may also be given K-exolate to cause them to have diarrhea to get rid of some of the potassium. And ultimately, the electrolyte imbalances are managed somewhat with dialysis. Nutrition is also a concern. We want to encourage food intake. A lot of times they don't want to eat, and then they don't know what to eat because their diet is so difficult to determine how to do it. So usually we get a dietitian involved in helping educate the patient on foods and what foods they can eat and what foods they can't. The biggest thing, though, for most of them is they just don't want to eat. They don't have an appetite. Mental and emotional status is also important as we're assessing our patients and helping them. They may be confused. They may be depressed. They may be anxious. And so working through some of that with our clients, oftentimes they're put on antidepressants, helping them understand the disease process and their treatment regimen is important as well. So our interventions relate to managing the fluid volume, We may administer diuretics in the early stages, but not usually after dialysis. Again, we want to monitor their intake and output, including their IV fluids. We want to be careful about not giving them too many IV fluids. We may give them antihypertensives, digitalis to control the cardiac function to make sure they have an adequate cardiac output. We may also work with our clients on recognizing and avoiding exposure to infections, because they're going to be more at risk for infections. Because of the edema, they may be at risk for tissue injury. They may be at risk for falling if they're confused, and so forth. This concludes this recording. I encourage you to read your textbook and go to the Nursing Reference Center and read more about health promotion and maintenance for these folks, and nursing care relative to chronic renal failure. Thank you very much.